Hello, it's Dr. Pearlz Clinical Rounds, and I have another clinical case for you. So let's get right into it. 7-year-old male presents to the clinic with a complaint of sore throat for the past 2 days. History is provided by the patient's mother. Patient reports sudden onset of sore throat and reports having a fever of 101 this morning. Patient reports abdominal pain and reports nausea and 1 episode of non-bilious vomiting. Patient denies cough, myalgias, runny nose, rash, ear pain, difficulty swallowing, diarrhea, and dysuria. Patient has been taking ibuprofen with temporary relief and denies known exposure to strep, COVID, or flu. Patient has no significant past medical history and has no known drug allergies. Patient is up to date with vaccinations. Vital sign is significant for a temperature of 100.5, and on exam, patient has bilateral tonsillar erythema and edema with exudates. Patient has abnormally enlarged tender lymph node on the left anterior cervical region, and abdominal exam is benign with no focal tenderness, rigidity, or guarding. McBurney's point is negative. There is no rash. Remember to assess for the presence of peritonsillar abscess, airway compromise, muffled voice, drooling, trismus, as this indicates more severe illness and needs prompt evaluation in the emergency department. What tests should you perform? A rapid antigen detection test, or RADT, and COVID-19 molecular or antigen testing should be performed. A throat culture should be performed in children and adolescents if the RADT is negative. The sensitivity of RADT ranges between 70 to 90%, but it has a high specificity of approximately 95%. Due to the lower sensitivity of RADTs, a throat culture, which has a sensitivity of 90 to 95%, is considered the gold standard. The IDSA recommends testing when symptoms are not strongly suggestive of a viral etiology. The IDSA also does not recommend testing children under 3 years old unless there are risk factors such as known exposure from a sibling or from daycare. This is due to an overall low incidence of streptococcal pharyngitis and rare incidence of rheumatic fever in this age group. Due to the low incidence of GAS and risk of subsequent acute rheumatic fever, throat cultures in adults are not recommended if the RADT is negative, but can be considered. In our patient, a RADT is performed and is positive for strep pharyngitis. So what is Group A Streptococcus? Group A Streptococcus, or Streptococcus pyogenes, is a gram-positive coccus that grows in chains and is usually transmitted through direct person-to-person transmission via respiratory droplets. Other causes such as foodborne outbreaks and environmental transmission is rare. The incubation period is approximately 2 to 5 days. GAS pharyngitis is the most common bacterial cause of pharyngitis in the 5 to 15 years age group and accounts for 20 to 30% of cases. It is seen most in the winter and early spring months in temperate climates. In adults, it is estimated that 5 to 15% of pharyngitis is caused by GAS. There is an increased risk for those working in occupations with close exposure to school-age children and amongst parents with school-age children. There are other bacterial causes of pharyngitis, such as Neisseria gonorrhea and sexually active persons, or Group C Streptococcus in college students and adults. What symptoms are more suggestive of a viral pharyngitis? Cough, conjunctivitis, rhinorrhea, discrete ulcerative stomatitis, diarrhea, vesicles, viral exanthema, hoarseness are more suggestive of a viral illness. Please note that the presence of viral features does not reliably exclude strep throat. As per the IDSA, it is important to note that clinical features alone are not specific to GAS pharyngitis and do not reliably discriminate between GAS and viral pharyngitis, except when overt viral features are present. So what viruses cause pharyngitis? Most viral cases are caused by viruses such as rhinovirus, RSV, adenovirus, influenza virus, coronavirus, parainfluenza virus, Coxsackie virus, Epstein-Barr virus, and herpes simplex virus. This is not an all-inclusive list. What symptoms and physical exam findings are more suggestive of GAS pharyngitis? The sudden onset of sore throat, pain on swallowing, fever, and nausea, vomiting, and abdominal pain in younger children may be more suggestive of GAS. In children less than 3 years old, symptoms typically present with increased irritability, decreased appetite, mucopurulent rhinitis, excoriated nares on infants, and low-grade fever less than 101. Diffuse adenopathy and exudative tonsillopharyngitis is rare. Tonsillopharyngeal erythema, edema, and/or exudates, red swollen uvula, palatal petechiae, scarlatiniform rash, and tender anterior cervical adenopathy may be seen on exam. Scarlet fever may develop with GAS. This is characterized by symptoms of GAS pharyngitis plus a scarlatiniform rash that is red and bumpy with sandpapery texture. Rash usually begins on the trunk and spreads outwards, spares the palms and soles. The rash blanches on pressure and will usually last for 1 week. Individuals may also get a swollen tongue with whitish coating or a red bumpy strawberry-like appearance. The testing and treatment is the same for GAS pharyngitis. Are there any clinical scoring tools to help guide decision making? The modified Centaur score and fever pain score can be used to help guide testing and treatment decisions. However, overall diagnostic accuracy of these scores have been proven to be poor in some studies. These scoring tools may be helpful in identifying low-risk patients for streptococcal infection where RADT and throat culture may not be necessary. What are the potential complications of GAS pharyngitis? Peritonsillar abscess, retropharyngeal abscess, mastoiditis, acute rheumatic fever, post-streptococcal glomerulonephritis, or sepsis may occur. So what is the treatment for GAS pharyngitis? Most GAS pharyngitis is usually self-limited with symptoms resolving over a few days. Treatment with an antibiotic will usually result in clinical improvement in 24 to 48 hours. Penicillin or amoxicillin for 10 days is a first-line treatment. If there is a non-type 1 penicillin allergy, a first-generation narrow-spectrum cephalosporin such as cephalexin and cefadroxil can be used for 10 days. If there is a history of anaphylaxis from penicillin, macrolides such as clarithromycin for 10 days and azithromycin for 5 days may be used as an alternative, but there are increasing resistance rates to macrolides, resulting in treatment failures. Clindamycin for 10 days is another alternative for type 1 penicillin allergic patients or when a macrolide cannot be used due to high resistance rates. The clindamycin resistance rates is approximately 1% in the US in GAS isolates. A 10-day duration allows for maximum pharyngeal eradication of GAS. Asymptomatic GAS carriers do not require treatment. Tetracyclines have high resistance rates and TMP-SMX does not eradicate GAS, so avoid these antibiotics. What adjuvant therapies can be used to treat symptoms or acute viral pharyngitis? Acetaminophen or NSAIDs may be used for pain or fever. Avoid aspirin in children. Topical lozenges or throat sprays may be beneficial. Ice chips or popsicles or warm liquids such as tea with honey may provide relief. Warm saltwater gargling as needed may also provide relief. While steroids are generally not recommended, if the throat pain is severe, a one-time dose of dexamethasone given either orally or as an IM or prednisone may help improve symptom resolution to within 48 hours. Always check for contraindications and discuss potential adverse effects when recommending any medications. Follow-up. Individuals may return to daycare, school, or work after 12 hours of antibiotic and if afebrile. If there is no improvement in 48 to 72 hours, reevaluate for complications or consider switching the antibiotic regimen. But otherwise, follow-up is generally not needed if symptoms are improving. Test to cure is not recommended. Throat cultures may take up to 3 days to return, and if you are waiting for the results, recommend supportive treatment for symptomatic relief. That's all for today. Thank you for watching. If you enjoyed the video, please hit the like and subscribe button. Let's move on to the next case.